Hello guys, this is Dr. Asif. Today I'm going to discuss about exam in our country Bangladesh, that is Bangladesh College of Physicians and Surgeons. Already they established a membership exam, that is MCPS, and also the most famous FCPS Part 2 exam, which is so much popular in our country. So as you know that qualifying exam is much bit tricky, but most of the students, or the above 80 to 90% student, are failing nowadays because they have no any revise, or there is some problem in collaboration about MCPS exam in different aspects of subjects, and also in the clinical exam they don't coordinate with the clinical and also the oral exam. So I tried my best to summarize some topic which are high yielding nowadays, and as my previous exam experience, and I just try to recapitulate something, and we just in this video and now on I'm just making a playlist that where I try to discuss about the long cases and short cases, which is a clinical exam, and also there's some topic in the viva, that is short specimen, surgical imaging, and the instruments, which is not sufficient, I know, but I tried my best to cover all the topic in a video. Okay, so let's start with the long case. Here you can see some long cases which is very common in the exam, and also there are some short cases which is nowadays is very common. So we just try to discuss every topic, or the minimalistic topic, or what is must to present in the exam. So as we know that MCPS pass rate, and the MCPS pass rate is average 25%, so which is very low, and you all know that passing this exam is quite hard. So I can't be so sure that you will be able to complete with it, but I can assure you that it will be helpful, I think. Okay, so let's start with the first long case, that is stomach. So let's discuss with some minimalistic things. Okay, so starts long case discussions, I think which will be helpful. So give me some likes and comments after completing the discussions. I don't call you that give me like in the first of the lecture, but if you like it, please thumbs up. It will give me a different encouragement to keep continuing the video. Okay, so start. So first of all, when your teacher will give you 15 minutes to cover your case, and just try to make a short salient feature. Okay, so all your long case have 30 minutes, I think. So before in that 30 minutes you will have 15 minutes for case discussions, and the last 15 minutes the question answer sessions. Okay, so first, my patient Mr. X, it would be anybody, that will be male or female, 55 years old, farmer, normotensive, non-diabetic, hailing from Pirojpur, Borishal, presented with the complaints of lump in the upper abdomen for 4 months and recurrent vomiting for 2 months, and according to the patient's statement, His presenting complaint started about 4 months back. Then he noticed a lump in the upper abdomen which is gradually enlarging in size and not painful. He is not experiencing fullness after meal and occasional rolling mass from left to right of abdomen. He also complains of vomiting for last 2 months. Also, almost every feed which is induced projectile in nature and the content is profuse in amount and foul smelling, non-bilious, sour in taste, containing partly digested and undigested food materials that he took previously. Patient also complains of loss of appetite and significant amount of weight loss for in last 4 months, and his bowel and bladder habit is normal and no features of metastasis. He has no significant past history, but he is smoker, taking 15 to 20 stick or bidi, which is called in our country, per day in last 20 years. But he is not alcoholic, not betel nut chewer. He used to take occasional anti-ulcerant. He is immunized according to the EPI schedule and he has no allergy to any drug or food. Patient is ill looking, cooperative, mildly anemic, non-ectatic, mildly dehydrated, and the nutritional status is below average. All accessible peripheral lymph nodes are not palpable. All other vitals are within normal limit. So on abdominal examinations, abdomen shape is scaphoid, flank and full, and umbilicus is centrally placed, inverted, no ingos vein but visible peristalsis is present which moves from left to right, and the hernial orifice are intact, and there is an intra-abdominal lump in epigastric region which moves with respiration, measuring near about 4 to 5 cm, which is non-tender, irregular in surface, ill-defined margin, and hard in consistency, non-pulsatile, slightly moves from side to side and above downward. So not fixed with overlying skin, and succussion splus is present. So just remember in the last word, that is succussion splus is present. So what is your diagnosis? So you have to complete your long case within presentation within 10 minutes. It's my advice to you, because you will have more time for your question answer sessions. So what is your diagnosis? My provisional diagnosis is gastric outlet obstructions due to carcinoma stomach. So what is the disease or other possibilities? That is the gastric lymphoma, GIST, which is called the gastrointestinal stromal tumor, pyloric stenosis, carcinoma transverse colon, because colon also labeled in the same plane just anterior to the stomach wall. So why it is a carcinoma stomach? So it's another question. So there's some point from your history, that is 55 years old, epigastric lump for 4 months, and features of gastric outlet obstructions. So these are the relevant points which is positive in your history, and the short 4 months is very short period of time. So here the key clues that why carcinoma stomach is the cause, where this patient is experiencing fullness after meal and occasional rolling mass from left to right of abdomen for 4 months, and he also complains of vomiting for last 2 months almost after every feed, which is induced projectile. And nature, the content is profuse in amount and foul smelling, non-bilious, sour in taste, and the containing partly digested food materials that he took previously. On abdominal examinations, visible peristalsis is present, which moves from left to right, and succussion splus is present. As I already told you about the last word, okay? So what are the causes of gastric outlet obstruction? These are general questions or the theory. In the recent years, the most common cause of gastric obstructions is the gastric cancer. So gastric outlet obstruction should be considered malignant until proven otherwise, because if the patient came with some points of positive findings, if you don't know what actually happens, so you should regard it as a cancer, because it is so common nowadays. And enterogastric carcinoma stenotic complication of the peptic ulceration is one of the most commoner among the cancers. Okay, the stenosis in the first part, the duodenum, stenosis in the pyloric channel, hourglass contracture, and the teapot deformities. It's one of the important findings, that is contrast X-ray findings. Okay, and the carcinoma head of the pancreas, lymphoma, Crohn's disease, duodenal hematoma, adult pyloric hypertrophy, annular pancreas, which is a congenital anomalies, and extrinsic compression by Ehlers lymph node. In case of gastric lymphoma, there are a significant larger lymph node which gives pressure to the luminal structure that causes obstruction. Other benign tumors, that would be the cause. So carcinoma head of the pancreas and annular pancreas and these cancers and also the lymph node are the commoner among all. So what do you mean by significant weight loss? Why you mean that? Okay, so unintentional weight loss of more than 10% of his previous body weight in the preceding 6 months, because I told you that the problem within 4 months and the losing weight rapidly within 6 months. So these two are very short period and a significant weight loss happen. So how will you assess the nutritional status in this case? So I will assess the nutritional status of the patient by history, clinical examinations, and some investigations, and the history. So this is the pattern that you should continue in your whole time period. How? And I will assess the nutritional status. This is the pattern that you should use in all your long cases. So I will assess nutritional status of the patient first, then I will take additional history and do some necessary clinical examinations and some investigations as well. And in the history you will have decreased food intake, loss of due to loss of appetite or dysphagia up to 3 to 6 months. Patients complaints of weight loss and clothes or jewelry clinical impressions like very thin average and overweight, all can be happened. Conditions of the hair, that is brittleness of the hair and lusterless, that is skin will be lusterless and not shiny, and the subcutaneous fat will be lost, and the skin will be dry, scaly, rough, and the muscle atrophy, initially temporalis muscle, then other skeletal muscle of the body, because here you will see the muscles of the scalp will be shrinked, and after all the facial muscles and also the whole muscle will be problematic. Okay, and the body weight, measurement of the body weight and the comparison with previous weight if known, or comparison with the ideal body weight tablets, that is BMI will be less than 18.5, indicate nutritional impairment. Okay, some laboratory investigations. So you will go for albumin. Serum albumin will be less than 30 gram per liter, an indicator of poor prognosis of prognosis, and lymphocyte count, skin testing for delayed hypersensitivity. So these are the things we will see in the investigation portions, and there are some other investigation which is necessary for diagnosis. The upper GI endoscopy with biopsy to establish the diagnosis and histological pattern of the disease, because we will take some tissue samples for histopathology. What kind of cancers or what kind of tissue there as a pattern. Okay, so ultrasonogram of the whole abdomen as the patient presents with the lump. So I will advise patient USG to delineate the lump and the size and extension of the lump. So By ultrasonogram, you will see the size, extension of the lump, or any liver metastasis, or any para-aortic lymph node present or not. And the CBC and ESR hemoglobin percentage reduced, ESR increased, and barium meal. It is helpful to visualize the distal segment when the endoscope cannot be negotiated properly beyond the stenosis, because it is a continuous, it's a continuous, the compressions or the formation of tumor is continuous. So there will be no chances of spontaneous relief of obstructions, so you have to remove it. Okay, there will be some para-aortic nodes as well, and the CBC with ESR and hemoglobin percentage reduced and ESR also increased. And the barium meal study, it is helpful to visualize the distal segment of the when the endoscope cannot be negotiated and properly beyond the stenosis, and the direct visualization of the size of the stomach for planning of surgery. For staging purpose, CT scan of the whole abdomen, chest X-ray CT scan of the chest, tumor marker CA7824, which is prognostic indicator, and all this 99 is a diagnostic. Those are two tumor markers. Endoscopic ultrasound is for staging, which is 77 to 100% sensitive. That is EUS and other investigations of fitness of the patients. So what is the role of diagnostic laparoscopy here? What is the role of diagnostic laparoscopy in carcinoma stomach? Here, laparoscopy with contact ultrasonography provide direct visualizations of low volume peritoneal and liver disease, as well as assessment of the extent of the tumor in the stomach. Peritoneal lavage cytology ensure the abscess of small volume peritoneal disease. So peritoneal lavage is very necessary here, and also the cytology. So we can see some fluid you can take for assessing any malignant tissues or cells present in the body fluid, like peritoneal fluid presence or not, you can see by laparoscopy. Okay, so peritoneal lavage and cytology ensure the absence of small volume of peritoneal disease. So peritoneal signaling, it seems that tumor goes three ways, like hematogenous metastasis, lymphatic route, and the direct seeding of the body cavity. So any metastatic seedlings or direct metastasis can be seen by the laparoscopy. So what is the role of CT scan of abdomen? What is the role of CT? CT scan of the abdomen definitely plays a role for staging and planning and follow up gastric cancer patient. CT scan of the upper abdomen is strongly recommended in case of proximal gastric cancer, where patient complains of remarkable epigastric pain in the younger age group less than 40 years, when patient does not complain of vomiting, when endoscopic biopsy reveals mucinous or signet ring cell carcinoma, which is very dangerous. So how many biopsies, it will be many, should be taken from the suspicious lesion? So 8 to 10 biopsies from the lesion and the perilesional healthy tissue. So why a lot of biopsies can be taken from the single or the different places? Because there is chances of false positive or false negative. Okay, so the 8 to 10 biopsies from the lesion must be taken. So now the $1,000,000 questions, how we will treat you. Okay, so these patients should be managed by the multidisciplinary team approach, MDT. Okay, because it is a very good starting approach. You will start with the multidisciplinary team approach. Patient should be counseled about the disease and the prognosis and protocol of treatment and staging and the outcome. A patient depends on histological type and tumor location, stage of the disease, fitness of the patients. So these are the topic that may vary the treatment portions or protocol. So informed written consent should be taken, and the patient preparation, correction of the anemia, correction of the fluid and electrolyte imbalance, and the improvement of nutritional status as well, especially albumin. Stomach preparation by gastric levels, yes, it's very important because you have to work in the stomach, and the stomach wall is very thick. That's why you can't do a good anastomosis in the stomach wall because of the edema, the wall thickness. So you have to make your make the stomach wall thin, and the muscles hypertrophied portion will be come to the normal. But how you will do that? By gastric level. So ideally 3 days preparation with orogastric or wide bore nasogastric tube, irrigation with 200 ml normal saline over 4 hourly until clear fluid comes out in between lavage. Only plain water or liquid diet can be allowed, okay, before surgery. After adequate preparations, I will plan for exploratory laparotomy with intent for resection of the tumor and bypass. In case of early gastric cancer, laparotomy should be done with intent of the curative resections, but or on exploration of abdomen assess for presence of ascites. There could be a presence of ascites. It is a danger sign or a sign of advanced malignancy. If there is any liver metastasis present or not, we can see some omental deposits present or not, peritoneal deposits, and assessment of local growth sites, okay. And the plan to perform lower partial gastrectomy with Roux-en-Y gastrojejunostomy. So if it is unresectable, that is if palliative, the tumor is engorged with malignant tissues and the serosa involved and the surrounding tissues like liver, gut, pancreas is attached, in that case the plan is only for palliative gastrojejunostomy. That is only gastrojejunostomy and chemotherapy, and follow up the patient. Now there are some issues which is very important, that is etiological factors, where the how or in which causes as the people got affected with carcinoma stomach, because there are some factors. Some are patient factors, some are environmental, and some are genetic factors. So host fact, that is patient factor. The patient with H. pylori, chronic gastric ulcers, gastritis, gastric polyp, pernicious anemia, gastric atrophy, and the previous history of peptic ulcer disease. And in the environmental factors, that we all know that all cancer has some evidence of mutations, like cigarette smoking, chronic carcinogen exposure, dust ingestion from industry, diet, ingestion of spirit, excessive salt intake, and seafood. Sometimes some seafood has nitrosamine compounds. It can cause early gastric cancers. Deficiency of the antioxidant and nitroso compound, which can be found in the seafood sometimes. Genetic factor like blood group A positive, heredity in the familial gastric cancer, germline mutation of E. cathepsin gene, CDH1. Other hereditary syndrome like Lynch syndrome and Peutz-Jeghers syndrome. So CD1 gene, that E. cathepsin gene, is one of the important hereditary factor by where the familial gastric cancers can be detected, which is established. And the classifications, yes, you're in the question answer sessions. If you go a very good way of other previous questions, some teacher will ask you, can you explain the classifications of carcinoma stomach? Yeah, you do, because there is a clinico-pathological classification which is also called the Lauren classification. Interstitial gastric cancers, and the another is diffuse gastric cancers. Okay, let me highlight it. Gastric cancers and the diffuse gastric cancers. Okay, here. So intestinal gastric cancer, carcinoma elsewhere in the tubular gastrointestinal tract, and forms a polyploid tumor or ulcers, polyp shaped. and the diffuse gastric cancer often with a signet ring shell. There in the histologically there is a signet ring cell present in the nucleus. It infiltrates deeply into the stomach without forming obvious mass lesion, but spread widely in the gastric wall and worse prognosis. That is worse prognosis. According to the depth of the invasions, gastric cancer can be divided into early gastric cancers and advanced gastric cancers. It defined as a cancer limited to the mucosa and submucosa with or without lymph node involvement. And advanced gastric cancers, it involves the muscularis layer. Advanced gastric cancer is further classified by type 1 fungating, type 2 ulcer proliferative, and the type 3 the ulcerative, and diffusely infiltrative or linitas plastica. Okay, this is a stage 4 tumor. So early gastric cancer is also called the Japanese classifications. Here Japanese classifications has some covariant, that is protruding, superficial or excavated. It has superficial, elevated, and flat, depressed. And type 3 is excavated, which has type 1, type 2 involved in the mucosa, whereas type 3 involves both mucosa and submucosa. So what there is a popular term, that is D1 dissections, D2 dissection, D3 dissection. What it is? It is mainly lymphatic excisions. So D1 is a group of lymph nodes, D2, D3 as well as a group of lymph nodes of different locations. So when a surgeon has to dissect a tumor along with the radical excisions of lymph nodes surrounding area, so he will limit himself from which and how extent a tumor with lymph node will be removed. That is regarded with D1, D2 and D3. So what are those? Different types of lymph node are needed to be removed depending on the positions of primary tumor general. So D1 dissection involves the removal of perigastric nodes along the lesser and greater curvatures. Okay. D2 dissections, that means D1 along with hepatoduodenal ligament, a root of a mesentery. And D3 dissection involved D2 plus along the hepatoduodenal ligament and the root of mesentery. D4 dissections involve D3 and para-aortic node and middle colic lymph node. Do you understand what I have said? This is very important because in the exam, sir will ask you what is D2 dissection. So D2 means D1 along with hepatoduodenal ligament and root of mesentery, which is very common during radical gastrectomy. How will you assess inoperability of carcinoma stomach? Some patient will come with some symptoms by which you can assure that the patient must not go for operation, because that will no improvement actually, and it will give him a lot more limited life expectancy will be very low. Okay, the clinical findings, that is jaundice, supraclavicular lymph node enlargement, palpable gastric lump, ascites, Blammer's shelf, Sister Joseph's nodule, fitness for operation, and these are the things. There is ascites, Blammer's shelf, Sister Joseph's nodule in the umbilicus, fitness of the operation. So these are the things you can see if you see these symptoms in the cancer patients, so you must not go for operation because it is a sign of inoperability. Some other questions usually asked: how many lymph nodes are required for TNM stagings? It is 16 at least. And after surgery, how will you ensure from the specimen that it is malignant ulcer? In the serosa of the stomach, just opposite to the ulcer site, there is petechial hemorrhage. So there is a hemorrhagic lesions. So that means patient tumor have already been moved on. What are the endoscopic treatment for early gastric cancer? That is EMR and ESD, endoscopic mucosal resection, which is very early stage. So people usually don't come in this stage due to some screening due to lack of awareness, and the screening facility is not always present in our country. But yes, in the Japan they usually do endoscopy, and they are invariably go for endoscopic mucosal dissections, as well as a patient go for endoscopy submucous dissection also. So that is all about the long cases. I know I have told you some different things in the long cases, but in the exam teacher will ask you the question, they will go for answers. Don't go for other things, don't go for any introduction, some conclusions, no, just what your teacher said about the questions, and you will give answer accordingly. No other things should be added. Okay, thank you very much. So if you like my channel, if you like my videos, please subscribe, and I will be stay tuned. Also, you will stay tuned with my videos, and I think it will be helpful in your exam actually the clinical exams, because written exam has a huge topic. It is not possible every time to continue the written topic, because there is very variety of topic here. It is not so easy to continue each and every topic on time, but yes, there are some clinical topics which is necessary, and I will try my best to explain in limited manner. Thank you very much. Stay tuned. Peace.